members logged in to support this committee. The Acting Minister of Health, Mayor Kubai Ngubane, and your team, welcome to this meeting that is scheduled to start just now. I will like to make these opening remarks that we have lost a member of Parliament in the National Council of Provinces, who is a co-chair when we meet as a joint committee with NCOP. She chairs. No, sorry, we have lost her partner, Mayor Gillian. She has lost her partner. Mayor Gillian is the chairperson of the Health and Social Services in NCOP. A lot of you members know her because we sometimes jointly have meetings with her. If you could send her a condolence message, it happened yesterday, and we just I spoke to her just today. Maybe if we start this meeting with just a moment of silence in recognition of one of us who has lost a partner. Thank you. May his soul rest in peace. Honorable members, we are meeting to receive a report from the ministry led by Acting Minister Kubai Ngubane. That is a program on the acquisition of other vaccines, the update on the vaccine rollout, and also I think the secretary will flag that agenda here. But before that, may I just confirm the members who have attended, if I could give that space to Mayor Machalamba, and also indicate members who have requested, who have sent apologies.
Good afternoon and thank you, Chair. Present is Dr. Dlomo, Mr. Munyai, Ms. Gela, Mr. Sokacha, Dr. Jacobs, Dr. Harvard, Ms. Wilson, Ms. Ishmael, Dr. Tembe Kwayo, Mr. Van Staden, Ms. Sukers, and Mr. Imam Sheikh. I haven't received any apologies. Thank you, Chair.
Honorable members, as I welcome you into this virtual meeting, I just want to make this reminder. Before we proceed, I would like to remind you that this virtual meeting is deemed to be in the precinct of Parliament and therefore constitutes a meeting of a committee of a National Assembly for official purposes only. In addition to the rules of virtual sittings, the rules of the National Assembly, including the rules of debate, apply. Members enjoy the same powers and privileges that apply in a sitting of a National Assembly. Members should equally note that anything said in the virtual platform is deemed to have been said in the House and may be ruled upon. All members who have logged in shall be considered to be present and are requested to mute their microphones and only unmute when recognized to speak. This is because the microphones are very sensitive and will pick up noise which might disturb the attention of other members. When recognized to speak, please unmute your microphone and connect your video. Members may make use of the icons on the bar at the bottom of their screens, which has an option.
Recording in progress.
Oh God. Members may make use of the icons at the bar of the bottom of their screens, which is an option that allows a member to put up his or her hand to raise points of order. The secretary will assist in alerting the chairperson to the members requesting to speak. When using the virtual system, members are urged to refrain or desist from unnecessary points of order or interjections. We shall now proceed with the business of the day, and I would like the secretary to just flag the agenda of our meeting for today. Yes, if you could then just make it big, some of us are struggling to check. Having done item 1, 2, 3, 4, we are now on item number 5, which has got sub-bullet A, B, and C. We would like to get from the minister an update on acquisition of vaccines. This is in relation largely, Minister, to an issue related to other vaccines, maybe to improve the pool of the vaccines that you have. We know that you may not have all the information. Maybe this might also make the committee to consider asking SAPRA to come and update us on those vaccines that actually are not yet in the country, but are still to be processed. How far is that process of actually acquiring those at the level of process by SAPRA and then available to you? The second part, that is how are you doing with the vaccine rollout? This is what, Honorable Minister, you continuously give us every fortnight. And the last part, to share with us this Delta variant. We would then engage with you after this presentation, and then you could then assist us to clarify. Honorable members, this meeting is going to be 2 hours because of other pressures that we all have. And we agreed that we will, if the presentation is 30 minutes, then we'll have an hour and a half to engage with the department thereafter. I now give this opportunity to the minister to actually open up and then assist us with the presentations, which I would assume it can be related, all A, B, C, D done at one time. Thank you, Honorable Minister.
Honorable Chair, I propose that in the next meeting, we need to have the item on the independence of the regulatory authority based on science, not politics. If in the next meeting, we can have that item so that it's important we engage on the matter. Thank you, Honorable Chair.
Okay, do write that to me, Honorable Munyai, so that I understand it well. We will not discuss that now. I will probably understand it much better. I hear what you are saying, but let's probably reserve that for this meeting, and then I'll take it and follow it up thereafter. Thank you very much. I now recognize the minister.
Thank you, Chairperson. Good afternoon, Chairperson. Good afternoon, honorable members. Thank you very much for this opportunity. I must firstly apologize for the DG, who will not be able to join us, but we've got DDGs and other team members who are here, who are going to be in discussion with the portfolio committee with us. This is due to the fact that he's got meetings with the AG that could not be moved. And then secondly, as agreed, Chair, we felt when we looked at the time that we'll do one presentation. So we'll take the members of the portfolio committee on those 3 items in one presentation, and I'll ask Dr. Anben Pillay to lead in the presentation, and then we'll come through. I think this is just on an update. Members would have noted that we've already briefed in public in terms of the presence of the Delta variant in the country, and that led to what President had announced in moving the country into alert level 4 with the restriction as per what we had agreed as cabinet to say, when the risks are higher, we will put more restrictions, and when the risks are lower, we'll lessen the restrictions. This is to assist us in managing the pandemic across the country. You'd see in terms of the presentation, Chair, that the Delta variant, though it has not completely taken over and replaced the other variant, but it is continuing to increase its dominance. And this will be explained so that we are able to clarify even those that are saying, perhaps you shouldn't have, for example, stopped the buying of AstraZeneca and rolling out AstraZeneca. At the time, Chair, that this has happened is because we had been advised that beta was dominant in our society, in the country, and therefore when you looked at the efficacy of AstraZeneca, you'd have seen that it wouldn't have assisted us in protecting the nation. So we continue to follow the evidence-based interventions and the work that we are doing. And that will be spoken to when we come as well to reflect on the current available vaccines in the country or that has been approved on the basis of the information that we receive as a country through the regulator that is there to do its work independently. So thank you very much, Chair. I'll hand over to the DDG to present, and then I'll come in again as part of the response, giving the response.
Good afternoon, Minister, Deputy Minister, honorable members, and colleagues. So my presentation today relates to the Health Portfolio Committee presentation on COVID, as the Minister has outlined. So moving to the next slide. I'm going to cover the epidemiology and surveillance, as well as the Delta variant, and just give you an update on the vaccine procurement as well. So, honorable members, you can see from this graph, which is the SARS-CoV-2 cases covering the first, second, and third waves, looking at a 7-day moving average of 100,000 cases. And the three graphs are superimposed so that we can get a sense about what's going on. And in the yellow graph, you can see that that's the first wave, and it was probably much lower, as you can see there. And then the second wave, which is green in color, was much higher than the first wave. And now we're currently with the third wave, and this is where it is currently, certainly threatening to reach the levels of the second wave or potentially even pass it. What you notice very interestingly is that the increase in the cases initially was low, and then suddenly at this point you can see the steepness of the curve and a much more rapid increase in cases across the country. Moving to the continent, honorable members, you can see that 5.2 million cases across the continent, which is about 3% of our global cases. This was up until about 24th of June, with about 139,000 deaths, so with a case fatality ratio of about 2.6. Still a bit lower than the 3.6 of global deaths, but there may be some reporting issues here. What you can see on the right-hand side is countries that have reported a one wave or two waves or three waves. And you can see generally across our continent, most countries have either had 2 or 3 waves. South Africa, we're in our third wave already, and so are many of our neighbors as well. Moving to the COVID-19 in South Africa, looking at cases, hospital admissions, as well as deaths. You can see the black line reflecting the number of new cases, and the gray area reflecting the hospital admissions. You can actually be excused for assuming that we're trying to shade in the area under the graph. But the reality is that hospital admissions very closely mimic new cases. So if we want to prevent hospital admissions, the key strategy has to be to prevent transmission of infection. The red line reflects deaths, and you can see there's also a very close correlation between deaths and hospital admissions as well as new cases. So preventing new cases become very important. This represents the R0, or what we call the reproductive rate. It's the average number of new infections caused by a single infected individual. So how many people on average does one infected person infect? And if the number falls below 1, that's very good, because it means that when I'm infected, I'm not able to infect other people, and that then reduces the spread of the infection. When the number gets above 1, that means I'm infecting more people. Not only am I infected, but I'm infecting more than one person. And so this currently is sitting at about 1.43 as per our calculation. We need to get this number down to 1. This gives us a sense about the daily tests as well as the proportions that are testing positive. And we can see on the left-hand side of the graph relating to the number of daily tests, and on the right-hand side, the average weekly proportions testing positive. Very close relationship between the two. As more people get infected, they come in to be tested, and there's increases in testing. And linked to the increase in testing is greater levels of case finding. We can see that the percentage testing positive is getting to a level of about 24-25%, which is about 1 in 4, which is fairly high. In some provinces. It's higher than 30%, such as Gauteng. So a significant number of people that are positive. It usually gives us a sense about if we went into any environment, what we would anticipate. So for every 3 or 4 people, depending where you are, you can anticipate that one of those individuals may be infected. They may not necessarily be aware if they are asymptomatic. Here, this a graph confirms the number of SARS-CoV-2 cases by province. And you can see very clearly that Gauteng is increased so significantly relative to all the other provinces. On the other hand, we can also see that the Northern Cape is declining. It hasn't declined to levels that are acceptable, but certainly it's moving in the right direction, and we hope that it continues in that way. We also see similar trends in the case of the Free State. So Northern Cape and Free State seem to suggest that they will continue to decline. However, the other provinces are all showing increases, some more rapid than others, and those are the areas where we have to intervene and make sure that we reduce transmission. This gives you a much closer snapshot of the more immediate period. The other graph was for the 2 waves, but this is just the wave that we're currently in and you can see the distinct difference between Gauteng and the other provinces, largely driven, we would anticipate, by the presence of the variant, as well as the compliance with the non-pharmaceutical interventions of mask wearing and social distancing. So you can see here that provinces such as the Western Cape are showing increases, Mpumalanga as well, Limpopo, KZN and Eastern Cape, much lower levels, but those need to be quickly stopped in order to make sure that they don't get into the blazing inferno that we're trying to stop. To give you a sense of the time series, on the 31st of May, we just had 2 provinces that had high levels of cases, and those were Free State and the Northern Cape, with the Northwest slightly behind. And over time, we can see that the Northwest increased, and then we had spread in the Western Cape, and now we have largely 4 provinces that are at high levels of infection: the Western Cape, Northern Cape, Free State, as well as the Northwest province. This is an output from the work of the modeling consortium, and you can see, similar to the previous graph, that most of the provinces have basically past the point of the definition of a 3rd wave. That's largely Gauteng, the Northern Cape, the Free State, the Northwest, as well as the Western Cape. At this stage, the KZN has still a little bit of time to go. You can see that on this graph here. Before they breach that level, hopefully there can be some interventions here, and this could stop the spread. The Eastern Cape as well were much closer to breaching that level, and in the case of the Western Cape, they've already done so, as you can see there. And the Mpumalanga province as well has a little bit of breathing space. In terms of our expected and actual all-cause deaths during COVID-19, the red line depicts the recorded deaths, the black line reflecting the cases, and then we have the predicted deaths in between. And you can see the expected versus the actual all-cause deaths with infection over time, graphically representing the lockdown levels that we had at the top, level, the lockdown level 5, the level 4, and then 3, and moving down, and now we've had to increase again, and the impact that's going to have on cases. Moving then, Chair, to the detection of the Delta variant, which was announced over the weekend. So we started detecting the Delta variant sometime in June, and you can see the rapid rise in the Delta variant. Prior to that, the yellow lines show you the Beta variant that was largely dominant in the country. And just over a short space of time, the Delta variant has displaced the Beta variant in a number of areas. You can also see, I draw your attention to the Kappa variant, which is in the pink color, and that is also emerging in some provinces. I'll give you a provincial breakdown just now, but very clearly that's another variant to watch. The Alpha variant you can see is largely petered off, very low levels of the Alpha variant at this stage. Going to the province of KwaZulu-Natal, here you can see increases in the orange area reflects largely the Beta variant. The green reflects the Delta variant, and you can see how over a very short period of time, the Delta variant has started to displace the Beta variant. And so we anticipate over a period of time that the Delta variant is going to get to much higher levels. And this may explain the dark line, which is actually the daily cases, the increase in the daily cases. So we anticipate that the Delta variant is playing a significant role in driving up the cases. Moving to the Western Cape, a very similar picture. Here you can see the Delta variant again increasing and displacing out the Beta variant. What's interesting in the Western Cape is this pink area here, which reflects the Eta variant. At this stage, doesn't seem to be as dominant as the Delta variant. We obviously must watch this, but this increase in the Western Cape certainly can be attributed to the Delta variant as well. Moving to Gauteng, you can see the rapid rise linked almost in parallel to the increase in the Delta variant and its quantity and the way it's moving. The Alpha variant still exists in Gauteng, but to a very low extent. And I think over a couple of weeks, we probably will see this entire portion of the graph being shaded green, as we anticipate that the Delta variant will continue and will displace the Beta variant. In the Eastern Cape, a fairly similar picture in terms of the variant, not moving as fast as the other provinces. Interestingly, there may be some theories about that. Seroprevalence seems to be one theory, given the Eastern Cape had such a severe second wave. But certainly you can see increases in the Delta variant's presence over the past couple of weeks, and we'll need to keep watching that to see how that progresses. But certainly contributing to the increase in cases, as you can see here. Limpopo, very similar picture to the other provinces, rises in the Delta variant, and also a rise in cases linked very closely to that. In terms of global distribution, I think it's important to say that while the Delta variant was sampled in India in October 2020, it is now detected in over 85 countries, including several in Africa, as you can see, across the continent, where they are able to actually do the studies to assess the variant. But in a number of other African countries, it remains quite endemic, as well as in South America, North Europe, as well as Southeast Asia, Australia as well. So it's a fairly dominant variant. It seems to be taking over from the other variants. In terms of vaccine registrations, let me just say that as you know, vaccines are considered for procurement after registration by SAPRA. At this stage, the Ministerial Advisory Committee on Vaccines would also advise the minister on the selection of vaccines, the procurement and the use of the vaccines in particular groups. SAPRA has to date, as you may know, approved the use of the Pfizer vaccine, the Johnson & Johnson vaccine, and the AstraZeneca vaccine. And we are currently procuring and rolling out the Pfizer as well as the Johnson & Johnson vaccine. SAPRA is currently reviewing the dossier or the data related to the safety and efficacy as well as quality of 3 vaccines: Sinovac, Sinopharm, and Sputnik. And the intention is to register these vaccines if they consider the data to be acceptable in terms of scientific standards. In summary then, Chair, if I can say that the Delta variant is now rapidly becoming the dominant variant in South Africa as well as in a number of countries across the world. There's now good evidence that the Delta variant is certainly more transmissible than the previous circulating viruses than other variants of concern or interest. Higher levels of transmission, Chair, mean that more people will be infected. And as I showed you in the earlier graphs, more infection does mean higher hospitalization as well. So we are obviously bracing ourselves for higher levels of hospitalization linked to this variant if it continues to spread at the rate that it is. There is some reduction in neutralization as well from the convalescent serum that has been collected post-beta infection, which does raise concerns about the potential for reinfection. So simply put, if you were infected previously with the beta variant, it is quite likely if you're now exposed to the Delta variant that you could be reinfected. That's what some of the studies are suggesting. So if you've been previously infected, you need to continue to wear your mask, social distance, and follow all of the non-pharmaceutical interventions, whether you've had a vaccine or not. In terms of vaccine effectiveness, this has been a question relating to the variant. So vaccine effectiveness data from the UK suggests that certainly there is very good protection against symptomatic disease and very high levels of protection against hospitalization from 2 doses of the Pfizer vaccine or the AstraZeneca vaccine. We don't have any data relating to the Johnson & Johnson vaccine yet, but from using our first principles, we would anticipate that the Johnson & Johnson vaccine will perform similar to the AstraZeneca vaccine, but we'll await the studies around that. So we anticipate that the Johnson & Johnson vaccine will be as effective as the AstraZeneca vaccine against this variant. Thank you very much, Minister and Chair. I will stop there.
Thank you very much. Thank you very much, Dr. Anpan. And the following members have actually indicated, there are 8 of them who have indicated that they would like to engage with the presentation. Now there's a 9th one.
I'm number 9, Chairperson. I'm number 9.
You can count very well. The first one is Honorable Sheikh Imam, number 1. Please, honorable members, once we have asked a question, the following one then must just follow immediately so that don't come in between. Number 2, Honorable Van Staden. Number 3, Honorable Ismail. Number 4, Honorable Kwahube. Number 5, Honorable Wilson. Number 6, Honorable Sokacha. Number 7, Honorable Sukas. Number 8, Honorable Dr. Jacobs. Number 9, Honorable Dr. Tembekwayo. And number 10, Honorable Munyai. Now, Minister, in your opening remarks, it was very interesting. You mentioned the issue of AstraZeneca. Now, I was just wondering what type of a debate is this one now starting in, because we were aware when AstraZeneca landed in our shores that the government was advised by scientists that it will not be effective against that particular variant then. And this committee and all of us were saying, we wish therefore that you could dispense of that without having any fruitless expenditure. And you did make sure that this vaccine was sold to some countries that needed that. Now, to come back now and say, no, the government should not have sold the AstraZeneca, but that AstraZeneca was expiring in April. What would have been the use of that AstraZeneca if we kept it now, now that we now know that it Delta? So I just think that explanation you gave is something that should just actually continue to shut that type of a noise, because I just don't know. Yes, if AstraZeneca is now effective, so be it, but we could not have used the AstraZeneca that came in February because it had an expiry date. And if we had left it and say we hope and pray Delta comes to our shores, only then we use it, would have been accused of wasting the taxpayers' resources. but maybe other members would ask questions. Let me then give the members to start in that order. Honorable members, start.
Thank you very much, Chairperson, and thank you to the department for the briefing today. The first question I have is, Acting Minister, I have sent you a correspondence with a whole lot of questions. Could you perhaps give me an indication when I could get responses to these questions that I have posed to you? That's the first thing. If you remember in the last meeting, I highlighted the success rate of a Dr. Shankara Chetty, who is now being recognized more and more worldwide. And together with that, if you look at what Minister Nkosazana Dlamini Zuma has said, that we simultaneously, while dealing with vaccine, need to look at alternative solutions. This is one of the solutions. My understanding is to date, you have not even contacted him. And I have a very serious concern of that. One that may have any solution to the problems of the country should be hastily considered, or at least have a discussion with them to see where it can actually take them. That's the next thing. The third issue I have is, I'm told that vaccines are being distributed to many sites, and some of these sites have vaccines still available because there's a slow take. People are not coming in to take these vaccines. What process have you got in place to redirect them so that they do not expire or get wasted and things like that? Because you know there's limitations in terms of that. Now I know, and I like what Dr. Anben Pillay spoke about the independence, and very importantly, he said that after registration, then only you will be able to procure. But I want to remind Dr. Anben Pillay and the department that's not true. That when we ordered the vaccines, the AstraZeneca, it was already on its way when an application was not even done at that stage. And yet you talk about independence. Can you please tell me about independence when the chairperson of your board and the husband is a director in a procurement company? Can we get independence? Can we get independence when the CEO of SEPRA comes from McKinsey, and McKinsey together with Aspen Pharmaceuticals and Johnson & Johnson have been involved in not only corruption, but mass deaths plus on the cancer related products that they've manufactured, upscaling the pricing? Don't you think we have reason to be suspicious and be concerned about what is actually going on in terms of that? Now let's talk about the Delta variant. In this particular portfolio committee, we highlighted this a long time ago, and we've even asked for measures to be put in place to stop the travel from India, because you knew what was going on in India. But once again, you failed to take timeous action. You've allowed it, and let me tell you the response. Some of the most ridiculous response came from the department. You were telling us that there's no direct flight, but people tested negative in India. When they landed here, they tested positive, because they even go as far as buy the COVID test results there. That's what is actually happened. There's been a death reported in the Eastern Cape in Mandela of a hospital worker after having taken the jab. Now, can you tell us what is the position in terms of this, or is the department now going to refute these claims and not compensate these people? Can you tell us what is really the latest in terms of what you've established? Now, I just want to go to this. There's a statement that was released by Johnson & Johnson on the 28th of May, that there's a plausible connection between their product and clotting plus thrombocytopenia. I hope that's the correct, but Dr. Jacobs will help me to correct my pronunciation. Despite that, neither the DAOH or SEPRA made any statement advising the public about this danger. Why? The World Health Organization called for a halt immediately on youth vaccination based on myocarditis, I think it's called, reported among young people in the United States after taking the Pfizer vaccine. What is your response about it? Are the parties aware of the preliminary report by Dr. Tess Lowry, where over 800,000 adverse event victims have been reported, but we're not hearing anything about it? So in a nutshell, I want to know how many, once again, people have tested positive after taking the vaccine, how many of them might have been infected, and how many of them have died? Why are we not getting these reports? You're giving us the PCR reports every day, which is unreliable anyway, but why are you not giving us these reports which we need If you can explain to me that, I would really appreciate it. But once again, I want to know what has happened to ivermectin. Where is the report from SAPRA, which I've asked in the last meeting, which you assured me you're going to look into? Why are they not giving us that report in terms of the settlement agreement, in terms of what they've agreed in court? So if you can just perhaps answer me that, I'll appreciate it, Chairperson. Thank you very much.
Thank you, Honorable Chairperson, and good evening to all the honorable members and to the Honorable Minister. Honorable Minister, in the light of the fact that only 2.7 million people have till now been vaccinated, and that includes our healthcare workers, and in the light of the fact that new variants are now getting more and more people infected, and that Gauteng is now under lockdown and people are now getting more infected in big numbers, will it not be better to completely open registrations for vaccinations for everyone above the age of 18, and that people who want to be vaccinated be helped on a sort of a first come, first served basis? I will tell you why. Otherwise, we as South Africa will take for a very, very, very long time to get our population vaccinated and to get those vaccinated who wants to be vaccinated. So in my point of view, I think we must speed up the process. I am currently aware of a 29-year-old patient that is Down syndrome and that is autistic and is in urgently need for a vaccine. Now, this patient cannot be helped at this moment due to the registration system that is only open for the ages 60 and above. And we know this coming week to come, the 50 to 59ers will open. But what measures are now being put in place to help disabled people who wanted to be vaccinated? I think that also must be looked at. And then my second question is, no one can or may be forced to register or to take a vaccine. However, I received complaints from educators that whose choice it is not to be vaccinated must now hand in sworn affidavits at the schools where they are working that stipulated why it is their choice not to take the vaccination. Can the acting minister please consult with ministers of other departments and bring the situation under their attention, please, as no one can be forced to take any vaccinations? My third question is, on the 25th of June this year, a circular was issued, and I have it in front of me, to heads of provincial health departments, heads of pharmaceutical services, district managers, vaccine program managers, vaccination site managers, and COVID-19 vaccinators. And in this letter, it is stipulated that pregnant women was excluded from COVID-19 vaccine trials, and that data to guide vaccine decision-making are lacking. It also states that clinical trials on pregnant women are now underway. Now, it is also stated in that letter that certain vaccines should be offered to all pregnant and breastfeeding women who are eligible to be vaccinated. My question on this matter is, how can healthcare workers have discussions with these patients to be vaccinated? And as this letter also states, and I quote, that these discussions should include the fact that safety data for vaccines in pregnancy and breastfeeding women are currently inadequate, close quote. And do you think this is the correct path to go with pregnant women, as there were no clinical trials done on them before? And how do we know that these women and their unborn babies will be safe while receiving these vaccines? So I think it's a matter that which we need clarity on. I also received complaints from people who is eligible to be vaccinated that they have been turned away at certain clinics here in Gauteng when they went to receive their vaccines, even though they have registered and received the SMS back and the date of the vaccinations. And I want to know, why is this happening and how will this matter be addressed? I think it's important to please explain the differences between all the variants which is currently now in South Africa, for South Africans to understand what we are talking about on these meetings, because many people are watching these portfolio committee meetings we are having with you and the department. My last question to the Honourable Minister is don't the Minister think that is now the time has come to allow the private sector and provincial governments to procure, store and distribute vaccines so that the vaccines can be administered at a much faster pace? Because like I said earlier, that I think we are running on a very, very slow pace at this moment. And it will take us, looks like now, it will take us forever to get everybody vaccinated who want to be vaccinated. Thank you very much, Chairperson. I appreciate it.
Good evening, everybody, and thank you for the presentation. I just have a few questions. My first question, Gauteng cases are significantly higher than other provinces. Now, why is this the case? What have they done differently, or what have they not done? My second question, has there been a cost-benefit analysis done by government on the impacts of further restrictions? Does the lockdown save more lives than it destroys? Do we have an evidence to back lockdown restrictions? And if not, why not? My third question, what studies are being conducted for J&J's efficacy for the Delta variant, and how long will it take before we can get the results of these studies? On the same point of J&J vaccines, please also advise if J&J will need a booster shot as stated in some
I've lost Honorable
Ismail. Honorable Ismail. Maybe she's not aware we have lost her. Okay. Honorable Kwahube coming. We'll go back to her if she comes back.
Thanks, Chairperson, and good evening, everybody.
My first question, the airport of fake test reports, or how sure basically asking is.
Honorable Ismail, you come back and disappear again. We are moving to another member. Try and improve your connectivity that side. We'll come back to you once you think you are okay. Honorable Kwahube, continue. Yeah, Honorable Kwahube, continue.
Hi, Chairperson. Yes, I'm here. Thanks for the presentation, and good evening, everybody. I have a number of questions. The first one being, of course, we can understand the issue around AstraZeneca and how that vaccine at the time was not effective against the variant that we had at the time. Now, what I'm more interested in is that what is the process of being able to source it and source the supply once again, since now that it has been sold, and how quick in terms of will SAPRA be looking at the scientific trials or scientific evidence that they had before, and will that mean that if the DOH and South Africa tries to source AstraZeneca again, it would not necessarily go through a longer process to try and get the regulator to essentially approve it? Of course, I don't expect the department to speak on behalf of the regulator, but it would be interesting to note whether or not this is something that we are able to source, and we are able to source quickly, considering the fact that clinical trials were done before. Then the second question is around the vaccination and the pace at which those are happening. 121,000 vaccinations yesterday were done. And this is a question that is recurring, Acting Minister, and it has been a question that we've consistently been asking. Yes, we've received, the commitments from the department that we're going to ramp this up. The target initially was between 250 to 300,000 people a day. Now that the category of people who are able to be vaccinated has been expanded. I mean, we're looking at over 60s healthcare workers who still not complete, people, teachers, those in the front lines. One would assume that, considering that a lot more people can be vaccinated, and considering the fact that we've been told that supply is now fairly consistent, why is it that we are still not meeting our targets? 121,000 vaccinations per day is dismal. It is, for a country that is basically in the throes of a devastating third wave. We are nowhere near where we need to be. So I would like to understand, where again is the throttling factor? Because when we have these meetings, we are told, we'll ramp it up, we'll open more sites, we will, we'll make sure that more and more people are being vaccinated a day, but it's not happening. And, and weeks are going by. The target of meeting of vaccinating 5 million over 60s was meant to be today. And I have no idea how many over 60s have now been vaccinated. But clearly, even despite the fact that there have been delays, we are nowhere near where we should be. Then the third question, I think Honorable Van Staden didn't touch on it. What is the view of the department in terms of allowing the private sector, professional bodies, and other players in the country to be able, under strict regulations, of course, that can be imposed, of allowing distribution of the vaccines? I understand there may be limitations in terms of what is the obligation of the department to how vaccinations can be distributed. But of course, now we're under the gun and we are chasing a deadline and we are completely underperforming. Surely, other players can come on board, and many various companies and various players in the country have come forward to say we're ready to vaccinate. Why is there reluctance or reticence to do that? Then the people with comorbidities, when are they expecting to be able to register on the system? There was a lot of talk around after 60s, we'll be opening up to those who are over 40 with comorbidities. That kind of language has kind of seem to fall away. And we get a lot of queries from people saying, I'm 39 or whatever, and I have hectic comorbidities. When will I be able to register? And I'm not entirely sure how the plan is, because now there seems to be a segue of looking at teachers and other frontline workers. And so what is the thinking of the department? What is sort of the sequence in terms of being who is next, and what is the rationale behind who will be next? And the last question is, what scientific evidence is so let me simplify it in this way. What is the department seeking to get, other than essentially building up healthcare system capacity during this lockdown? Because I suppose now that the issue around balancing livelihoods and lives is now yet a more urgent question than it was during the first lockdown. We're now in a third lockdown, and it's a lot more urgent to open up industry. So what is the department saying they are seeking to achieve in the 2 weeks that there is going to be a shutdown? And what kind of markers of success can we as an oversight body look at to see, have you achieved it? Because the first lockdown last year, the department said, well, we would like the 21 days to build health system capacity. 21 days came and went, more lockdowns came and went, and there wasn't really tangible system capacity that we could point to. So if we can get some kind of tangibles so that we too can look at what we can judge you on at the end of this lockdown period. Thank you.
Honorable members, if you are able to switch on your video, if your connectivity allows you, please do so. But otherwise, if you have a challenge, we'll also accept. But try and switch on your video when you speak. Thank you.
Thank you, Honourable Chairperson, and thank you to the Acting Minister and Dr. Pillay for the information shared with us. However, while I'm principally covered on some of my questions by speakers ahead of me, I do have other questions I would like to have dealt with. And the first one is, and there's an awful lot of information circulating about this at the moment. We obviously do have the anti-vaxxer communities who are constantly talking about the amount of people who've had bad reactions to vaccines, who've died, who've had heart attacks, who've had embolisms, who've had the whole bang shoot. And I think it's very important that an assessment on this is done and that we actually get figures with regards to how many people have had bad reactions, severe reactions or deathly reactions, and from which specific vaccines. It's hard for people, people hear the anti-vaxxers and say, oh, all these people are dying or have got COVID or died after a vaccine or had severe implications after the vaccine. And This kind of information is quite important, particularly for those of us who are trying to defend the fact that vaccines must take place, or who are supposed to be encouraging people to take vaccinations. Because obviously, if 1% of a million or 1%, of large numbers are having a bad reaction, that is to be expected, because we know that a lot of people have reactions to vaccines for a lot of different reasons. And these kind of percentages will assist us in discussing these issues with people, saying people do have bad reactions to vaccines, some worse than others, but it's 1 in 100 or 1 in 1,000 or 1 in 1,000,000, whatever it may be, so that we can calm the situation down. And I think these kind of things need to be communicated. So if we could please have some kind of information around that, I believe it is very critical. I hear what Dr. Dlomo says about the AstraZeneca and the fact that we sold it on because we couldn't use it. And I had a concern with that at the time. And the reason given was that we had a low efficacy rate against the variant that we were probably dealing with at that time. Now, this is understandable, but only to the point. A low efficacy rate for me is better than not having a vaccine and having no protection whatsoever. And I found that very concerning, because I believe that some protection is better than no protection. And the end result is that we sold on a vaccine that could have potentially today have saved a lot of lives. So I do have a concern about that, and I go back to what my colleague, Honorable Khwarubi, said. Are we getting it again? How quickly can we get it, and how quickly can we start distributing it? We are seeing very, very different symptoms out of the current Delta variant. The symptoms are very different to those of the first 2 waves that we saw under a different variant. And I don't believe that enough is being done to communicate the changing symptoms. I have several family and several friends who are currently suffering with COVID, and the most prominent sign, the most prominent thing that they had was very severe headaches. And I don't think people are aware of that the symptoms for the new variant have changed considerably, and that people should actually be watching out for something different. Because they are similar to flu symptoms, I think people need to be made aware that please double check. It may not be flu. If it is accompanied by a severe headache or whatever, please go and get yourself checked. People are ignoring it because they're telling us they've got flu. They haven't got flu, they've got COVID. I think more needs to be done with communication of that. In your slides and on the one, Limpopo particularly, and Dr. Pillay, you said you would come back to us with regards to the Kappa variant. In the slides that you showed us very briefly, Limpopo was the one area that had quite a significant rise in the Kappa variant. If you could just give us some more information on that, and potentially why Limpopo versus the others has a higher while we have more Kappa variants visible in this province, which is where I come from, versus other. And it's not on your slides, and it's probably a bit earlier, but I think we need to know the difference between the transmission versus deaths on the variants that we have seen, the Alpha, the Beta, the Delta. Is there higher death or morbidity rates in the one or not? Was there higher morbidity rates in the Alpha, or is there higher morbidity rates in the Delta? If you can perhaps give us some information on that. I want to go, and I reiterate, and this was covered by the Honourable van Staden, the slow vaccine rollouts is unacceptable. And when people are not prepared to take up the vaccines, and they are not prepared to take up the vaccines at the moment because of misinformation or disinformation, or no information, what are we going to do about it? And and just this last week before last, I went to have my vaccine at Clicks. I took along my husband and I took along my Anna, who stays at my house and who's been working for me for close on 30 years. She's part of the family. We were queuing at clicks to be done. And obviously they could, in terms of how many people they can do per vial, they were only accepting so many people. So they ended up turning away 3 or 4 people because, or it was 2 or 3 people, I think, yes, saying we can't do you today because we can't use or open another vial. We're not going to be able to finish a vial if we vaccinate you today. Please come back and try again tomorrow. Having said that, my husband, my Anna, and I continued to queue. When we got to the stage where it was time to give us the vaccine, my husband and my Anna were turned away because they did not have medical aids after we'd sat there for nearly 4 hours. So I don't think that is acceptable. There are people waiting who are desperate for the vaccines, who are prepared to take the vaccines, and there are those who don't. And they ended up with a situation where they turned my husband and my Anna away, but ended up with a situation where they had a half full vial, which was the very reason why they turned people away earlier in the day. I think that is a problem. And given the growing numbers and the fact that we are in a 14-day lockdown period at the moment, but we are seeing numbers still exceptionally high. And I suppose you can't answer this, and I know that you won't, but further lockdowns are another likelihood. And I think we're missing the mark on this completely. If we're not vaccinating and people are not taking up the vaccines and not effectively communicating very important information to people, we're going to continue with the lockdown, that this is something that this country quite simply cannot afford. Thank you, Chairperson.
Honorable members, please assist me. Let us try and give space to other members also in our questions. Honorable Sokacha.
Thank you very much, Honorable Chairperson. Let me also welcome the report from Dr. Pillay and our Minister. Just 2 questions and 2 points of clarity, Chair. The first one, Dr. Pillay said that the numbers are dropping in the Free State and in the Northern Cape. I just want to, as a layman, Honorable Chairperson, I just want them to assist my assumption. My assumption as a layman might be that the number of testing is dropping. People are not coming forward to test. Or it can be that our people are adhering to the COVID-19 regulations. I just want to be assisted in my assumption, Honorable Chairperson. The second one is also a comment. I'm very happy that Dr. Pillay said vaccination can only be considered for procurement after the regulatory body, which is SAPRA, has registered the vaccination. I'm very happy that he has stressed that. And the second one, he also mentioned that the vaccination has got advantages. That is, they protect our people from a high level of symptomatic diseases, and also from a high, intake of hospital admissions. And he said more particularly if you've got your second dose of your Pfizer and your AstraZeneca. Then my last question, Chair, is around the good example that has been followed by the Limpopo province. They go out and to reach out for our people at the villages and the remote areas, more particularly for our elderly people, because they might not be able to come to the center of town and so on. I'm sure, I just want to check, Honorable Chairperson, through the good leadership of our minister and our deputy minister in the department, are they advising other provinces, more particularly the province like my own province in the Northern Cape, KZN and the Eastern Cape, where there are a lot of remote areas? Are they advising those provinces also to follow a good example of Limpopo? Thank you very much, Honorable Chairperson.
Honorable Sukars.
Hi, thank you, Chairperson. I am going to just ask, firstly, to the Minister, thank you for the presentation to the department. We have stated this before, and I think some of my colleagues has alluded to it as well. The Delta variant, the highly infectious Delta variant that is now driving infections, which virtually collapsed the Indian healthcare sector, is now driving our third wave. The previous minister was asked by this committee why travel from India has not immediately stopped and tracking and tracing of persons who travel from India was not instituted. Does the acting minister know why these questions were not taken seriously? And if the department can give this committee an account of that, why that was not done? And if we have done that, countless lives would have been saved. What practical steps is the acting minister going to take to avoid a repeat? And what plans does the minister have to ensure the department treat questions asked by this committee as serious? And I want to underline that really, Chairperson. Secondly, the field hospitals, the Delta variant, which now seems to be the dominant strain in our country, is propelling a dramatic increase in hospital admissions, an acute shortage of ICU beds. Are any field hospitals still open? And what arrangements are being made to reopen field hospitals or provide suitable alternatives in provinces like the Western Cape, in which the third wave will shortly strike? Then on the question of vaccines, both the Pfizer and the J&J vaccine, I have asked this 5 times. This is the 6th time that I'm now asking the question. Has used stem cells from aborted fetuses in either of their developments, either in production or testing. This could be a factor driving vaccine hesitancy among people who have moral objections. When the previous minister seemed unaware of this, I offered to facilitate the bio information, which we did. On a Sunday, the minister's spokesperson asked for the information, which I assume was in preparation for meetings with the faith and the religious communities in that coming week. Now I'm going to ask the acting minister again. Are there research for the reasons for vaccine hesitancy? I can tell the minister just from my encounters with my constituency that there are religious objections on the basis of what I've just mentioned. Secondly, will the minister consider acquiring ethical vaccines, so to speak, that does not use those cell lines? Then last year, a study conducted among clinic patients visiting clinics for TB or for HIV treatment for neonatal visits showed some 40% had developed antibodies to COVID-19. A survey was also conducted among blood donors. What is the current level of community or herd immunity? And if the acting minister is unaware, what studies are underway to measure this? Then, we are receiving regular reports of vaccine supply constraints and warnings of possible future constraints. The Honorable Siviwe did a good job of speaking about strategic sourcing. I'm going to underline it nonetheless, Chair. Countries that have been successful in the vaccine rollout have been ready for contingencies. We appear to be shocked by every setback. We repeatedly questioned the previous minister about the department's capacity to conduct strategic sourcing or procurement, and we urged him to draw extensively on the private sector. Will the acting minister now act to implement a comprehensive sourcing strategy? Then, I want to ask the question what Honorable Sheikh Imam has raised as well. Why does the department continue and SAPRA double talk on ivermectin? SAPRA and the DOH are under court judgment to make ivermectin available. Can the minister tell us what are the numbers on the compassionate program in terms of access to ivermectin? And how many applications in terms of Section 21 have been made and how many have been granted? Then there is an issue, Chair, that this committee must take very seriously, in my opinion. It is the impact of communication, not only in terms of what Honorable Wilson has so articulately expressed here, but also in terms of the impact of how we are communicating the daily stats of deaths,
on COVID-19 as well as infections, and the impact of that on a nation who has no strong support in terms of psycho support or mental support for people in trauma. There is a collective trauma that our people are experiencing. In fact, members of parliament that are working, I know, are suffering greatly because of the pressures that we are under. What is the impact of how we are communicating daily death rates and infection? And is there a different way in which we can communicate it? Then, lastly, Chair, 2 comments. The one is that COVID-19 can be overcome. People, it's got more than a 90% recovery rate. That needs to be communicated because our people are gripped in fear. And we need to make sure that we tell people, you can survive this. The department must take an approach that is much more positive in how we are addressing this. Then, lastly, there is a direct correlation between adherence and compliance and trust in government. This committee's chair cannot afford lip service from the department anymore or death by PowerPoint. So I am pleased asking the minister and for the committee here that all the questions that we are asking is in the best interest of the people that we serve. The department must do better to act on the questions that the committee has consistently asked since last year in December when we came back early. Thank you.
Honorable member. Okay. Yes, Dr. Jacobs, yes.
Can I continue, Chair?
Yes, you must continue.
Thank you, Chairperson. Thank you very much for the presentation from the Minister and from the department. The one question that I keep asking myself is, what is the most important thing right now for any person within South Africa? And the answer is very simple. It is what is good for that person and that person's family. How does this thing impact on the life and what are the deaths? And how does that impact on every single person? And how does it even impact financially on the people? When you get sick, as we all know now, it's going to cost you a lot of money. If you, for example, have to pay through a medical aid, or whether it's going to be a family member who needs support, etc. There's going to be a lot of economic challenges for all people who become sick with COVID-19. So, bearing that question in mind, I need to ask myself, why have we shifted so much towards the vaccines? Now, I understand I am also one of those who push vaccination lives. But I want to ask, why are we not talking about the things so much anymore as we did within the first wave, when we were going out there to actively support people, promote non-pharmaceutical interventions, explaining to people, having communication strategies, the different WhatsApp groups which were formed, the different platforms which were opened on which we could find and seek interventions. I don't see that anymore. I don't see the kind of reporting we used to have where people could go onto a platform and really just easily find what is happening in the immediate vicinity. Now, I know we're talking at a national level, but I also understand that our national level has some means of interaction. For example, the provinces and the provinces with the districts, etc. So when I come back to that question, I must ask myself now: this third wave, we knew it was coming. It is here now. How does it impact on our hospitals? How does it impact on our people who are patients, on those who are to have operations, those who receive chronic medicines, those who at the district health services, our healthcare workers themselves? We're not talking about it anymore, and I am just raising from my side a concern. How does it impact on the hospital levels? I've also raised the question constantly about the field hospitals, for example. Yes, I understand all of these things do cost money, and all of these things in the current economic situation that we are challenges. But I am requesting that we really keep on speaking about this. We keep on speaking about admissions, bed occupancy rates, oxygen needs, needs of medication, informing people where to go to. You know, we have learned so much from the first wave and the second wave, and we have really beaten the first wave and the second wave, and now we have the new Delta variant. And obviously, we are going to learn from the new variant, Chair. So, you know, I hope you can understand what I'm saying. I'm saying, yes, let us continue with the vaccinations. Yes, let's have the vaccination drive. Yes, let us move fast on the vaccination drive and get all the vaccines which can be approved to be approved. And we make certain that we save our people in that way, because we need to reach population immunity. But on the other hand, let's pick up on what we learned before. Let's start with our community awareness programs, our screening and testing sites, our sites where people can go to for quick screening, where people can go to and quick testing, where people can go to be hospitalized. And I will constantly say that the mainstay of treatment for any patient, as soon as a person starts being ill, is the supply of oxygen to that person, because that saves lives. We know that it has to do with the saturation, oxygen saturation in the blood. As soon as somebody drops now below 92%, you are in trouble. And we need to get those messages home, drive them home, get the communication strategies right, which we used to have in place before. And in the same way, need to protect our healthcare workers. And very last question, Chair. I noticed that there are no data for the J&J vaccine, but I do have a concern that all our healthcare workers were vaccinated with the J&J vaccine. I would hope and I would think that there must be a study somewhere that is looking at the immunity reached by those who were vaccinated with the J&J vaccine. What impact would that have on the health of our healthcare workers, so that they'll be able to continue to deliver the services which they are delivering? Thank you, Chairperson.
Thank you, Chairperson.
Thanks.
And thank you for the presentation from the department. I just would like to start with the first one. There was Sisonke findings that were released in April, and of which out of the 288,368 South African healthcare workers who were vaccinated with Johnson & Johnson vaccine, 50 of those had severe and or serious side effects. That number that was never mentioned in the presentations that were done, including the presentation for today, because there was only a mention of very few. I mean, very few. A number of 50 cannot be comparable to a term very few. So my question is, what happened to those 50? Is the department aware of them? And is there any report that, can we have a report on that, if there's any? And if there's no report, I also would like to know why, because in actual fact, the committee itself is associated with the Sisonke people who are doing the research thereof. And then I would also have engaged the department on matters of AstraZeneca, but unfortunately it was clearly said by the chairperson of the committee. But I would like to say this new information on AstraZeneca is indicative of confusion, of the department and lack of consistency as the order of the day. I mean, South Africans would like to receive information that is consistent, especially when it comes to health-related matters. The following question is, I would like to ask the minister to say, what is your take on the SAPRA association to pharmaceutical companies led by Bill Gates and Melinda Foundation, and more specifically, including the issue of conflict of interest, whereby they received 27.6 million and 45 million in 2019 and 2020, respectively, from Gates Foundation, the very same Bill Gates who has shares in Johnson & Johnson. That's why we say, Minister, we need definitely vaccines from other countries, as we have reiterated on this matter, to say, can we have vaccines from Russia, China, and Cuba, which would indicate a move away from the American vaccines. And I think South Africans will be satisfied to hear of such an announcement from your department. The following questions: why are the people who are on medical aid and who register successfully on EVDS, but are allocated places where they can receive vaccines very far from their places, from their residential areas? I am making reference to non-discovery medical aid holders. And please, Minister, can you go and check on the number that people call to find out about the availability of vaccines and their places? Because the responses that people get from that line, it's not professional as we expect it to be, because that is a line that serves the South Africans, but we are not satisfied by the responses that we get from them. And the last question is that your rollout plan is not clear enough, and we need an open, solid plan, rollout plan that can be applauded by all South Africans. When can we expect it to have that from you? Thank you.
After Honorable Munyai, we'll try and get back Honorable Ismail. She did not complete her questions.
Honorable Chairperson, there's no doubt, I think first and foremost, we welcome the report, both two reports from the ministry. Education. Sorry about it. We welcome two reports from the ministry, which are the one that really give us the current state of affairs with the vaccine as well as the Delta variant. And I think we welcome that report, and I'm sure as the portfolio committee we should adopt that report as a very important progress before this portfolio committee. There's no doubt, Honorable Chairperson, there's no doubt that COVID-19 vaccine can provide protection against many dangerous variants, such as Delta and the others that has been mentioned here today. It is very important that we demand universal global access to vaccine, especially to South Africa, Africa, and the rest of the developing countries. It is within our national interest as the Republic of South Africa that all our people as a whole are vaccinated as practical and urgent as possible. And the vaccination number in these instances, Honorable Minister, has declined. Is this maybe have to do with the lack of vaccine or the lack of vaccine supply, or it is a lack of human resource capacity? It is very important to understand that. Honorable Chair, the United Nations Chief Economist, Elliot Harris, argued the following, open quote, "The timely and universal access to COVID-19 vaccinations will make the difference between the promptly ending the pandemic and placing the global economy on the resilient recovery trajectory, or losing more years of growth and development and opportunities," close quote. All we're trying to plead with the ministry is that while we welcome the report, we need more supply of the vaccine. We need whether the people are affected, whether our people are really in a situation where there's a poor socioeconomic status. In fact, regardless of the socioeconomic status, whether a person in Tsitsikamma in the Eastern Cape, whether the people are in Springbok in the Northern Cape, and whether people are in Hamutele in Limpopo, the people should have access to vaccine at equal rate. And we know it's not an easy intervention, because this have to do with the logistic, cold chain, and so on, which need to contain this vaccine at a particular temperature. So therefore, as the ANC members of parliament, we are very solid, and it's our view that the rest of the continent and the developing countries should have access to vaccine as a critical national interest, especially in South Africa. And we support the efforts that really the military, in fact, we need also to request that the military need to come and intervene as well in the deployment of the vaccine to these needy areas. We already know, Honorable Minister, that the business sectors is already receiving nearly $1 billion to be able to roll out vaccine. But we are saying that to strengthen the capacity of the capacity of the developmental state, as we aspire to be in the ANC, as the ANC, we need to make sure that we strengthen the capacity of the state by making sure that the military, like any other countries, are able to be allowed to vaccinate our people and the rest of the population. Thank you, Honorable Chairperson.
Honorable Ismail.
Thank you, Chair. Firstly, apologies for being cut off due to bad connectivity. I hope I can, get through my questions now. So where I stopped was my fourth question. What mechanisms do we have in place to ensure people coming through the airports are not bringing in fake test reports? Or how sure are we that these reports are actually true? So the gist of the matter is, what test verification methods are being put in place? My fifth question, is there any data available to show long-term effects of each vaccine? This is very important, as we are getting some reports stating that, people are dying the next day after taking the vaccine. But I think, communication to the citizens out there is important, because sometimes people just hear of this and they start panicking, where they don't want to take the vaccination. So communication of, the symptoms, communications of the, efficacy of these vaccines are very important, and enough of this is not being done. I want to also stress, that by now, the department should be aware we are in a third lockdown, basically, and the third wave, and the department should be aware that they should have been already sourcing vaccines from more than one source. Now, my sixth question, I've been called by many healthcare workers, they are having a problem registering on the system. I'm also going to stress again the efficacy of the J&J vaccine is most of our healthcare workers got the J&J vaccines. How sure are we that the one jab is enough? Honorable Minister, we are losing lives rapidly. Our vaccine rollout is extremely slow. Why are vaccinations not taking place on weekends as well? The issue of budget. I think budget is compared to lives is something we need to deal with. Honorable Minister, how prepared are our health facilities? We had the first lockdown and we were told that, the lockdown is taking place to prepare our health system. And we are now in a third wave, and we still have issues of not enough beds, not enough ventilators, not enough of vaccination supply, oxygen supply. This can't go on. Really, this can't go on. And my last question, Honorable Minister, it's not dealing with COVID, or maybe in some way dealing with COVID, but we are facing a pandemic that is taking lives at a rapid speed. We need as many hands available as possible to assist, yet our interns and comm service doctors are not getting placements. Now, this is unacceptable and it's unfair. Their lives are dependent on their placements. Their lives are put on hold simply because the department has not planned effectively. Some have already wasted they wasted 6 months. They've wasted 6 months of their lives. How are they expected to carry on with their lives and careers? Thank you.
Okay. No, thank you, honorable members, for your questions. Just from my side, it's just two, honorable minister. The issue of there are no serious side effects is a very important negative reporting, which will always take away and allay the fears. I'm not aware, but I know that the healthcare workers do communicate at the vaccination site that if you get a mild headache, take a Panadol. If you are feeling unwell, just lie down. And those are not necessarily to be documented serious side effects to be reported. But you probably need to educate us of the serious side effects. And if you do find them, just that continued reporting, it will help in allay to say there are no serious side effects that have been recorded to date, or there is one after injecting 2 million South Africans. That part, I think, will also assist us, but it will depend how quickly the clinicians and hospitals are providing you with information, because again, it must be us as the population that must still come and report that I have developed an embolism here or this and that has happened. So you can only report in as far as how much we bring you that information back to you. To emphasize the point that was brought by Honorable Sokacha, a good story to tell from Limpopo. That story needs to spread very quickly because Limpopo is like other 3 provinces that are very rural, but for them to actually have a significant number of people who are coming in from this uninsured population registered for vaccine is something to be commendable, and that lesson must be learned quickly. Yesterday, Minister, I was listening to Professor Abdul Karim Slim talking about this variant, that it is very transmissible. It's easily transmissible, but he was not able to comment about how, he was not strongly commenting about how virulent or how dangerous it is. But it's just that it will make us flood hospitals once you are infected with it, and therefore cautioning us. But are we seeing a number of, are we getting admissions into general wards, or we are beginning to see most of the ICUs in most parts of our countries filled up, so that we are already experiencing challenges? If maybe, Minister, I like the part that was raised, and it's not, I mean, firstly, we do agree with the Honorable Kwahube to say at that time we could not have kept that AstraZeneca, but if there's a consideration of getting it now that we have got a Delta one, is that something that maybe the Minister is thinking about or the department is thinking about? Thank you very much. You can then help us with the responses, Minister.
Thank you very much, Chair. I'm going to request Dr. Pillay and Dr. Chris to come through. We do have as well the DM with us, and then we'll wrap up.
Thank you, Minister. Should I start? My connection is not very good, so I won't put on my camera. That's okay. I'll deal with the questions relating to COVID, and then Nicholas can cover some of the ones relating to vaccines. If I can say that in terms of the third wave, after the second wave, we had been planning that we may have a third wave. And so we have been working with our provincial colleagues. We developed what we call the RESURGENCE plan, which outlines the lessons that were learned from the second wave around hospital beds, around oxygen, around PPE, around human resources, as well as medicines, and what needs to happen at a particular point in time in each provincial department in order for them to be ready. They all have that. They have the planning tools. We try and assist them as best we can. Obviously, this does require information from them in order to say, I'm having a problem here. We do monitor bed occupancy as well. In terms of adding new beds, we had a meeting with the provincial heads of department. The DG called that meeting this week, and we had a discussion with the HODs about planning for the additional beds. They've all already had the plans in place, aligned with the resurgence plans. Most of the provinces have have closed their field hospitals and are using the current facilities or expansion or extension of the current facilities and the alternative building technologies, simply because of some of the challenges in order to make sure that this is something that can be more sustained. Because if you used a field hospital, you probably have to close it after a while, and then some of the resources in there become lost. But if you have it in your own facility, you can keep that for a longer period, and the investment is more cost effective in that context. So most provinces, if not all, have taken that decision after initially procuring a lot of the field hospitals. On the question relating to the Free State and Northern Cape, I can say quite clearly that the testing is continuing at the usual rate. However, there is certainly an adherence to the COVID regulations or the advice, or what, as some scientists say, is when people see around them that there are many people that are getting ill, your family members, your friends, etc., landing in hospital, or some of them even pass on, then that initiates a behavior change. The problem, though, is that that behavior change sometimes is short-lived, and we consequently then have people that forget to use a mask and social distance, and then that's what drives the next wave, and then they learn again and then forget again. And so we need to get them to consistently apply the non-pharmaceutical interventions, because that's the most effective mechanism. The question around how do we compare between the alpha, the beta, and the delta variants. The alpha variant was the initial variant. It was not as transmissible as the beta variant and had a fewer mutations on it. The beta variant was far more effective in transmission and was much more virulent. Now, from the beta variant, we have the delta variant. We certainly know that the delta variant is capable of being more transmissible than the beta or the alpha variant. And we don't know yet, in terms of its virulence, whether it's going to cause more severe disease than the beta variant. But what is very clear is that if you have a virus that is more transmissible, it does mean that more people will be infected than they were with the beta variant. And as that happens, those that are more susceptible will certainly need hospitalization. And so that's the approach we're thinking and taking. And in Gauteng, that's largely what's been happening, is that many more people are getting infected far more easily than they would if they were taking the beta and the alpha variant. So being extra cautious is probably the most critical thing in order to make sure that transmission doesn't happen. I think it's important to say that in terms of transmission itself, that this seems to happen in a shorter time frame. There's a number of studies that are being done globally since the 85 countries that are affected across Europe, etc. They're predicting that the transmission occurs at a much shorter period of time than it would with the case of the beta variant. In terms of what do we want to achieve with the lockdown or the level 4, I think one of our key objectives here is to make sure we can reduce transmission, which will then reduce hospitalizations and will have the knock-on effect of a reduction in mortality as well. I think that's our key objective here. In terms of the hospital beds, whether they are general or ICU beds, we're certainly seeing many more people being infected, and some of them are going into ICU. As I said, if more people are infected in a particular population, you can certainly see many more then getting into ICU as a result of that. So I think that's important to bear in mind. And then finally, Minister, I just wanted to show these two slides that relate to our rationale behind the selection of the age groups for vaccination. This comes out of our database on mortality. It's what we call the case fatality ratio, and it relates to the DATCOV system, which the National Institute for Communicable Diseases develops. And here they've looked at age and sex for the period 5th of March 2020 through to 5th of June 2021. And what is most stark across this is you can see that as age increases, the case fatality ratio increases significantly. So if you look at an age group above the age of 60, you can see that they are sitting with a case fatality ratio above 30%, going in the case of the 80s above 50%. Why am I showing this graph? Is to make the point, if you opened up the vaccinations and just said anybody above the age of 18 can go in for vaccination, since that's the age at which the vaccines are currently registered. And if you have a person who has a risk down here between the age of 30 and 39, you can see there is a massive difference in the risk. So in other words, if this person who's 30 to 39 gets infected with the virus, the likelihood of mortality is far lower than a person that is 80 years old. So the objective with vaccination is predominantly at this stage to protect the high-risk individuals from being infected and then having the severe effects of that, which is hospitalization as well as mortality. I'll just show you this graph as well, which is what we call the odds ratio linked to the risk of mortality. And this is hospital mortality. The data comes out of South Africa. So what you can see is when you have an odds of 1, it basically means your chance of mortality is equal whether you had that condition or not. And you can see as age increases, the mortality risk increases phenomenally. This is what this graph is telling us. Now let us look at comorbidities. This is the equivalent point where your odds ratio would be equivalent. You can see here that whether you had hypertension, diabetes, chronic cardiac conditions, kidney disease, etc., your risk is much lower than these age groups. Or here, if you look at which province you're in terms of the healthcare system, whether there are any differences there, there's no significant differences in terms of those issues. The key issue remains age, and that's the reason why we're using age as the key variable in determining who we vaccine first and second, etc. Thank you, Minister. I'll stop there. If there's other questions, I'm happy to answer them.
Thanks, Dr. Pillay.
Sorry, Minister.
You can proceed, Dr. Treasurer.
Thank you very much, Minister. Evening, Chair, evening, Minister, Deputy Minister, and members of the House and colleagues. Thank you very much. I think maybe if I can just give some high-level comments on numbers first and then respond to some of the questions. So as of today, or as of yesterday, we had registered just under 4 million people on the vaccination system, and we had vaccinated at that stage. Well, today we crossed the 3 million mark of total first dose or total vaccinations that we have given to people in the country. Obviously, 480,000 of those or thereabouts were done during the Sisonke trial with the J&J vaccine, and the rest have been done since then, since the 17th of May. Now, what we are tracking and tracing at the moment to understand where we are registering and vaccinating, and to build on what Dr. Pillay has said about our targeting of the population. We know that at the moment, the total population registration coverage is sitting around about 53% for the target population, but it varies a lot from province to province, and we have lessons to learn from that. It's the highest in Limpopo, which is at 74%. We have said this before in the public space. It means that it's not, and the second highest is the Eastern Cape, and it means that it's not necessarily the urban areas that are performing well. In fact, it is the rural areas. In fact, the low performances are in the urban areas. Vaccination coverage is around about 47 to 50% in KwaZulu-Natal and Limpopo of this target population, whereas in some other provinces it's still below 25%. And there are specific problems from one province to the other that we are trying to understand at district level and to assist them. Now, what's interesting is it's very different between the insured population and the uninsured population, whereas in the insured population, whose numbers are significantly smaller, we have that obviously the lowest vaccine coverage is in the rural populations, where a relatively small proportion of insured people have in fact registered. Whereas in the in the uninsured population, the rural provinces are doing better than the urban provinces and are getting above 50% vaccination of the uninsured target population as of this week. So we are trying at this stage, district by district, to establish which districts' services are doing well and poorly, and we have identified that a significant portion of the problems or challenges of those that are not performing that well is because they don't have a lot of vaccination sites, and the vaccination sites are hampered primarily by geography, but also because of the concentration of the private sites in the metropolitan areas. So for instance, Ngungundlovu has the highest vaccination coverage of all districts in the country, with over 70% of the target population reached, and Ugu being the second highest, whereas we have the districts in the Northern Cape where the distances are very far, and they were going to rely on the Johnson & Johnson vaccine, which has only just arrived and is being used not in the population program yet, which I'll speak about in a minute. They are struggling to get their rates up above 20%. There are some areas, some districts where we are identifying that the gap between registrations and vaccinations is very wide, and in others where it is very small. And where it's very small, it means the demand is running out, and that demand is often in areas where the registration is high. So it means that that is why we've taken the decision to open to another category, because otherwise we will run out of the demand of the age group 60 plus. And we have also learned from evidence from other countries that it seems to be that when you introduce particularly the 50 plus population, they tend to be the children of the 70 pluses, and they take the elderly people with them along the vaccination journey. So we're hoping that we are going to monitor that and see whether that makes a difference. The registration of the 50 pluses starts tomorrow, and before, at least by the 15th of July, we will be scheduling and seeing 50 plus people being vaccinated. There was a question about how much vaccine we've got. We have now, just in this past week, received vaccine from the Pfizer vaccine from the COVAX facility. We also get Pfizer from 2 separate contracts, so we now have received doses in this quarter from the 2 contracts. And of course, we've received Johnson & Johnson vaccine, which has been announced by the minister in the media, 2 different deliveries. Previous week, Thursday, and this past week, Thursday, that we now have received 1.5 million doses of the short expiry date vaccine, which we are using in the intensive programs in the essential services. We have been criticized for the slow uptake and the number of people we're able to target, and we know that we are moving towards a 200 to 250,000 and hopefully in excess of that vaccinations per day. We are up in the past week from 85,000 average per workday to over 110,000 at the moment. And as new sites are being brought online by both the public and the private sectors, these numbers will start to increase. We are targeting specific districts that are trailing behind. There was a question from one of the members about equity, and that's a concern because you don't want to leave parts of the country behind. Want to make sure that every district's people in the target populations are being reached. So at the moment, we have 53% of the target population registered. Just under 40% of the target population has been vaccinated. And now that we have vaccines and are rolling out additional sites, we are confident that we will start to pick up speed very quickly. And at least for the month of July and into the first week of August, we're confident of our vaccine supply. Beyond that point, we are still in the process of stabilizing the vaccine supply. We're confident we will be able to get that stabilized. Ideally, we would want to reach at least 65 to 70% of the target population. So now when we register the 50 to 59s, we will continue to register and push the drive for the 60 plus registrations. So there's definitely improvement in what we are able to do. That's not to say we are not trying very hard to up these targets and to move much more quickly, and we have a multi-pronged approach to do that. The private sector are definitely distributing vaccines. They're definitely vaccinating. They have a large number of sites, and we have meetings with them twice a week. And we appreciate the way in which we are working together very closely to make sure that we reach a bigger population. We also have agreements now with the private sector that they will vaccinate the uninsured population. So the challenges that were referred to by some of the members of uninsured people being turned away from private sites should be a thing of the past. And it should be possible now for uninsured people to be vaccinated in private sites, just as well as insured people will be vaccinated in public sites, especially in rural areas where there are no private sites at this stage, obviously because of the economy of scales. So that we have stabilized that relationship, and it's going a lot more smoothly. I just wanted to emphasize the point about we mustn't let our guard down just because we are doing better with vaccination and it's improving all the time. And the point from the Honorable Jacobs about continuing to wear our masks and do our hand protection must not be forgotten as we move into a better vaccination period. So I think I must, maybe just a last word to talk about the Limpopo success story, which was referred to by the Honourable Chair. It appears to be, the difference appears to be the way in which they've mobilized the community and the community leaders rather than any particular system. They actually go to the communities very proactively, and they have involved all of their MECs, all of their departments extremely efficiently. So that is a lesson that we must definitely spread to all the provinces. I think I'll stop at that point. Thank you.
Jim, you want to come in before I come?
Thank you. Greetings to our honorable colleagues from the Portfolio Committee. I'll just deal with a few issues. I think the team has dealt with quite a number. Just one, the question from Honorable Imam Sheikh about the Delta and why we didn't stop traveling. I think this matter has been dealt with. I know he's still not happy about the fact that we said we don't have any direct flights, but we're part of the global village. When you look at the fact that unless you go back to the total lockdown and total grounding of movement, as long as there's movement and people move from area to area, I mean, you could, go to the extra of on every airline, checking where people have stopped over and so on. But the question will be whether, what you will achieve through that will be worth the cost and the effort when you have many other areas where you can get maximum impact. So I think it was really a balancing act, and it would be a different matter if there was plane loads of passengers coming from New Delhi, from Mumbai, coming directly here. Then you would have some way of managing that. So I know that some honourable members still remain unhappy with that. Honourable Van Staten about just opening registration. I know Dr. Pillay did deal with that, showing the rationale, the scientific rationale of age differentiation. Clearly, there is more to gain because, as he has shown in one of the slides, basically what has been proven is that your hypertension, your diabetes, heart disease, kidney disease, and so on, generally speaking, those non-communicable diseases which largely go with, which are also shown over and over again to be the risk factors in terms of serious illness, have a very close relationship, if not very direct, with the age, the extent of age, and therefore using that as a kind of a differentiation you're able to also at the same time just beyond just the risk factor of mortality and morbidity in terms of age, but also it captures also your other risk factors, which also get more and more with advancement of age. I think the role of private sector, the colleagues have already dealt with. Now, the question of Honorable Ismail about why Gauteng. Clearly, we all know that Gauteng is the center of our economy in terms of business. So in terms of travel, people who come travel all over the world for various purposes, whether it's business or leisure or whatever. Yeah, it's largely into Gauteng. And once there's as it has been shown, the increased transmissibility, once that arrives in Gauteng, Gauteng is also the most dense of our provinces. So that's why the transmissibility, once the virus arrives in the center of our most cosmopolitan city, province. The question of AstraZeneca, whether maybe not, one should not go back to the argument of whether its limited efficacy on the beta variant was correct to dispose of it, to sell it to other countries. With the current information that it's quite efficacious when it comes to the Delta, there will be clearly no need. It's already registered. Its safety has already, the only question at the stage was not really in terms of safety. It was more of efficacy, and efficacy specifically in terms of a particular variant. There will be no need to seek any further approval by the regulator. And I think Dr. Crisp has dealt with the fact that, the thing which determines how speedily we move are basically two factors. It's availability of vaccines, and also once the vaccines are there, the human resource capacity, and so as the stock mainly is stock, because all the provinces have already identified the sites and potential human resources, but to activate those, especially where we have to pull in additional human resources, you can't do that until you've got stock. And as it's indicated, as the reliability of stock improves, you're able to activate more sites, bring in more people, and we can assure honorable members that as this stabilizes, hopefully we can get stability also with the J&J, and also with the dominance of the Delta. And I hope that we can still be able to access further stock from AstraZeneca, from the Serum Institute. That will go a long way, while we're looking at the other sources like Sputnik, Sinovac, and so on. I think maybe just having dealt with that, I think just to agree with Honorable Jacobs that it's important, honorable members, that we continue to emphasize that while vaccination has shown to add to protection, it's not a panacea to dealing with this pandemic. It has been shown not only in our country, where we're still early with the vaccination, but in countries which have been quite advanced with vaccination. As we learn now, that in countries like Australia, the number of cities which are under lockdown. There was also a report from Professor Abdul Karim about what is this island? Colleagues will remind me, with less than 100,000 people were having vaccinated, but they have got to come back to lockdown because of the fact that the Delta is also, descended on them. I'm sure colleagues will just remind me the name of our
Seychelles, Deputy Minister. Seychelles.
Yeah, they have done the vaccination. They've got less than 100,000 population. They've done almost everybody, but they've got to take measures because, notwithstanding the vaccination, they've been descended with a severe, a third wave of the COVID. So it's not a panacea. I know that those who want to whip up the government for everything, want to promise the population that you just have to vaccinate, then it's Uhuru. I think it's a set. Unfortunately, in real life, that's not the fact, and so we must always make sure that our population is aware of that. So the NPIs must always be emphasized. Agreeing with the colleagues, the rollout plan. I think it's honourable members may not be satisfied. I'm sure, honourable minister, when we come back, we can again maybe just to reiterate a full explanation of the plan and in terms of where we are in terms of the execution. I don't know if I'll just comment on this, but I would request Anban, also Dr. Pillay, just to come back just on the facts. This issue that SAPRA is allegedly captured by Bill Gates and what, that can't be any far from the truth, because, while there are a number of donors from time to time who contribute, especially SAPRA, when SAPRA was being set up, when it had to catch up with the backlog, there are a number of funds which were sourced from various sources to help SAPRA to clear the backlog, and they've gone a long way in terms of doing that. But this in no way, they stick very much to the principles of the science of any medication which comes through, and they work only on the question of whether this is compliant with the requirements. Maybe, Minister, before you come in, if Anban could just, I think he was already in the department, he could just shed some more detailed lights in terms of where the Bill and Melinda Gates Foundation contributed to some of the funding to help SAPRA clear the backlog when it was started. Let me leave it there. I'm sure, Anban, quickly, can you just maybe lay some more facts on this matter? Thank you.
Minister, can I come in?
Yes, please proceed, and then I'll close up for the first round of the questions.
Thank you, Minister. I think, yes, I think it's important just to understand the way SAPRA operates. SAPRA has a number of technical committees that when they receive an application for a medicine, each of these technical committees evaluate an aspect. So one committee will look at the chemical structure and its stability. Another will look at the way the tablet or the injection has been put together, whether the process, etc., is appropriate. Another group would look at how was it manufactured. Another group looks at when the drug gets into your bloodstream, how does it work, or any other part of the body, etc. And these are all different groups. Each group needs to then come back and report on whether they are supportive of registration or not. And then that process then gets pulled together to a point where there is then a positive recommendation from all the committees. If one of the committees has a problem with a particular product, then SAPRA will not be able to register. So when we focus on individuals in an organization, particularly the way SAPRA operates, they don't really have that kind of power to register a medicine or not register the medicine. It's largely process driven. Most of the regulators across the world are also structured that way. So no one person can make a decision about it. In terms of specifically the funding from the Bill and Melinda Gates Foundation, as well as a number of other donors, when SAPRA started up, moving from the MCC into SAPRA, there was a massive backlog of applications. And as a result of that, they needed many more people to come on board, both from South Africa as well as from internationally retired evaluators, to come and assist us to get through that backlog. Obviously, funds were required, and these donor organizations offered to make donations for that. But the donations didn't go directly into SAPRA's account. They were facilitated through a process with the National Treasury. Like many of us, many of the departments receive donations from donor organizations, but the funds come usually via Treasury in many cases, or the support is in kind. So I think it's important to bear that in mind in terms of the way that was done. If I can also just share on the J&J vaccine, I think the question on the thrombocytopenia, that's well known, and that adverse event is reported in the literature, as well as to healthcare workers, and patients that receive it are counseled about it and advised if they are prone to this, they should not be taking the vaccine, and doctors would advise patients who are at risk not to do so as well. In terms of the myocarditis, similar situation. There is very small numbers in terms of this. We can certainly, I think many members asked for more information about what is the overall adverse events relating to each of the vaccines. I think we can probably provide that. I think the Honorable Imam Sheikh had a number of questions, Minister, that I think he posed to you in his letter, and a lot of it is statistics. So I think we need to just get much of that, like, the ivermectin report, etc., which I think we promise to get and we can provide. Thank you, Minister. I'll stop there.
Very much, Dr. Pillay. I think just coming on the issue of surprise one, and also because Honorable Sheikh Imam made reference to conflict of interest of individuals, and specifically because publicly there's been an issue that Dr. Rees has conflict of interest, which I want to refute. We have looked at the matter. I've looked at the matter. Dr. Rees' partner was in a partner previously, but the BE has since lapsed, and she or neither he are involved with Aspen, nor J&J, any J&J products. So I think that was checked. I've had a conversation with Dr. Rees when the matter was, and maybe I must say, honorable members, one of the things that as parliamentarians and as members of parliament, that we must be able to act within principle is to protect institutions within this country, not for individuals to be intimidated, because we'll battle later to find professionals who are willing to serve, because when we fight, we personalize matters, we attack. Worse, it was women who have been attacked and literally threatened that people will go and do a sit-in in their homes. I do really think that it's something that we should, as even, I hope, members of parliament would stand as lawmakers who protect institutions within our country of democracy, and institutions that are supposed to support us to enhance our work, but also standing against, we talk about gender-based violence in this country being one of the pandemics that we are dealing with, and you have people who can stand and attack women because of the responsibility they have taken in this country to lead. So I do think that for me, it's important to clarify this and really say that I hope members will stand with us and really say that what has happened against SAPRA's leadership is uncalled for. That's the first thing. Secondly, the letter, honorable member, we will respond to a letter, but remember, in terms of the rules of parliament, it's questions that have a deadline that we have to, an obligation in terms of responding. We'll respond to a letter, but we can't put a time frame because it's not a tool that is used, because it's not a committee letter, it's an individual member's letter that we have to respond to. So within the rules, we will respond in the time frames that are allocated within. And within
Point of
this
order,
level,
Chairperson.
we're able to get the numbers and the names of the people that are being able to do. Then coming to the issue of honorable, I think others have been responded. Honorable Van Stenen Matters has been responded. Honorable Kwahube Matters has been responded. And as we said, we'll continue the issues of travel as well. Honorable DM has responded because the issue of travel, we operate within a global community, and there are practical steps that can be done. But I understand that Minister Mkhize has even responded to this issue, honorable member, previously in the committee, as you are saying that you're asking questions and we answer them. But it doesn't mean, honorable members, when you ask questions and we answer them and it's not within your satisfactory, they are not answered. We answer questions within the context of how we do our work and how we operate as members of the executive. Now, the issue in terms of research hesitancy, there's been quite a number of research that has been done. I've been quoting two specifically. That has been done, one by UJ, linked with HSRC, and then another one under Sachi Chair that is funded by Department of Science and Higher Education, Science and Innovation in Soweto, where there are multiple issues. One, correctly, around the issue of community leaders. Obviously, you say in this context, they've been making a reference of traditional leaders, traditional healers, and it could be deduced out of the research that because some of these leaders in the community, if they do not give the indication of safety or even comfort with the vaccine, it's likely to influence those that believe in them and those that follow them. So that is the issue. Then the other issue is it was around the distance, the issues of where people are located to travel to the vaccine. That's why part of the issues is around how do we respond, and the issue around the good story about Limpopo, bringing the vaccine to the people. Because one of the things that is found is around the issue of people who are not able to go where the vaccine is because of being 60 plus or that population, and the issue of the cost that is related. It's not all of them, but again, the other issue when you look at it, it's around for example, the issue of registration in terms of what Dr. Chris has answered. So we're looking at all those things. That's why there will be a multiple response area in terms of intervention from a system point of view, from what we will now call coordinated vaccine that needs to be arranged by the leaders so that we can be able to get a vaccination. I think we'll continue to do the work around the issue of acquiring moral vaccine. We currently do not have what we could be able to say this is what is would comfort those who believe in terms of religious beliefs that they can't take this vaccine, but we continue to advocate for this vaccine to help them. The issue of impact of communication, I think the other issue which would be around honesty and transparency. So we are required to be transparent in our reporting, to be honest in what we are doing and accountable. And I do hear what Honorable Member is saying in terms of sometimes it puts a lot of pressure on individuals and therefore they end up being depressed and all those things. I've seen the number of people dying. But in terms of statistics, you've got to be accurate, you've got to report openly, you've got to be transparent in the reporting. But I think one of the things that we always emphasize is around support, social economic, taking care of the social issues in terms of, that's why some of the people who talk about pastoral care, when we meet with the leaders of the churches, we talk about that, but we talk as well from the traditional leaders providing support and within communities, but also ourselves as members of parliament, we remain having responsibility in ensuring that we provide that. I think quite a number of them have been responded to as well. The issues around what Honorable Temegwayo, what Honorable Munyai has raised. Indeed, the President Ramaphosa continues to be the champion about global access to vaccine and as well making sure that vaccine is equitable. You'd understand in various platforms that is taken, Honorable Munyai, that he's been vocal about this to say we need to ensure that it's not only those who have are going to get access to vaccine, but everybody, from issues of developed countries and developing countries, from individuals who are coming from, based on the inequalities that we have, we must make sure that we roll out the vaccine to even the most remote areas and the rural areas and the most poor and the vulnerable. So that's what has been advocated by our government to ensure that we do continue to ensure that we are able to do what we are expected to. I think, Chair, I've been able to close off all the issues that were outstanding from the reports, and we can take further more questions if they still exist. Thank you very much.
Yeah. Honorable members, thank you very much, Minister. There are 4 members that I've recognized, and I've really engaged them on a chat group that will take 1 question per member, a follow-up, because we have been here with our staff members from 9 o'clock in meetings, and therefore we may not extend it too long beyond this 7 o'clock. So the people that I've recognized and their names are in the chat group is Honorable Van Staden, 1 question, Honorable Sukers, 1 question, Honorable Wilson, 1 question, Honorable Sheikh Imam, 1 follow-up. Those are the ones that I've recognized. I've asked actually also Honorable Sukers, who also came in and said, look, please, can you follow up by writing it down so that we can release our staff members and all of us who have been in this meeting. In that order, Honorable Members, 1 to 4.
Thank you, Chairperson, for the second chance. I still do not hear what measures will be put in place to help our disabled people in South Africa to get vaccinated faster for those who do want that. And I still do not hear measures what is going to happen to fast track the vaccinations throughout our population. And I would gladly like to hear from the Honourable Minister by what time and date will South Africa be completely vaccinated? Because if you're going on this pace, I'm afraid it's going to take us a very, very long time. Thank you, Chairperson.
Okay, next.
Honourable Chair, thank you so much. I won't be long. I just want to say thank you to the Minister for that direct response on the ethical vaccines. It is appreciated, and we really trust that that will be part of the rollout at the soonest possible time. Now, Chairperson, I need to say this. We are unhappy. Unhappy is not the word. It is unacceptable is the word in response to what the Deputy Minister has said. The Minister Zweli Mkhize in May said that they are urgently looking at the ports of entry. Nothing was done. It's a note that must be made by the committee. So the escalation in cases has directly to do with how we've managed the ports of entry and how the Indian variant has escalated because of the failure of us managing the processes. The practical issues, Chair, is very important that was raised by the physician in our committee. The issue around the practical steps of non-pharmaceutical measures and comprehensive care. We need practical examples, Chair, because we are already seeing the signs in my constituency of a rerun of what we saw in January, with the health services being under pressure, and that we don't have emergency services that are responding timeously to people who are in need of oxygen. So the issues that were raised by Dr. Ken, we need those practical answers to be given to us. And although I appreciate the fact that the Department of Health does academically respond, we cannot afford academics. We need the practical output of what is being done. The status of the field hospitals, where that is at in all the provinces. We need to know what is being done in terms of augmentation to ensure comprehensive care. Those are my notes, Chair, that I just want to bring to the attention. And again, thank you, Minister. I am relieved that you have acknowledged at the very least, the need for the ethical vaccine. Thank you.
Honorable Wilson. Oh, not there. Or muted. Honorable Sheikh Imam.
Thank you very much, Chairperson. Chair, allow me to express my disappointment. So many questions that I have posed, and just the department attempted to respond to 2 questions. But let me also add my extreme disappointment at the response of the Deputy Minister. I'm actually shocked at his response, whether it was worth the cost and the exercise in putting restrictions. Yes, it is, Deputy Minister. It's not your people, it's our people that are dying. If you put the measures in, our people, you could have saved some life. We said, stop the Indian travelers coming into the country. But you are saying you have to do an exercise to see if it's worth the cost. I'm actually very disappointed at your response. Acting Minister, I've said to you about Dr. Shankara Chetty. I don't know why your department believes that you are alone yourself. Person who is recognized worldwide. And I've spoken to many doctors in the last week or 2 who have indicated they are all using a similar treatment and it is working. Why are we not considering these things but just talking about evidence-based? When you talk about, I've given you evidence based on health, on the World Health Organization, which has stopped the rollout of some of this vaccine. When it suits your department, you'll accept it, evidence. When it does not suit, you won't. Why have you still not contacted this doctor, which might go and save many lives in this country? Thank you.
Honorable, that was the other hand I'd recognized. Okay. Then we're giving back to the minister and his department.
Thank you very much, Chair. I think let me start with the issue of travel. Perhaps maybe there's a misunderstanding of what the DM is saying. And because I've been extensively involved as well. When you look at issues of travel, in terms of traveling, what we have as a country, when we get info and what we have put in place, when we get traveling, we don't do only what we are doing. So similar within the health space, the aviation space will have international protocols, the travel and tourism will have international protocols, and it will have guidelines on how countries respond in terms of travel and in terms of how things are done. So based on that, that's what government would have looked at holistically to say from this side in terms of what is being said by UNWTO, by what is being said by global aviation industry in terms of traveling and how restrictions are done. The current issue is that we should not close international borders because they impact negatively as well on the pandemic. But again, honorable members, let's remind you, the country has adopted a risk-adjusted strategy. And in that process, we said the importance of balancing lives and livelihoods. So we save lives, but we also save livelihoods. So in the process of that with travel, when the matter of Delta was discovered for India, part of what as government we have put in place is that all travelers that arrive in the country within 72 hours, you need to have done a test and produce your negative test results. This is what is being done. If you arrive in the country and then you have been screened by Port Health, and then you are found to have symptoms in the process, then you are isolated. You are requested to go into a quarantine of not less than 10 days. So to say that as a country we have been reckless, we have not put mechanisms and measures in place to protect South Africans is not correct, is not true. Unless if honorable members have missed that part of the directions or of the regulations, because it's very clear. Anyone who arrives, whether even from countries that we think that they are safe, they have been received across, whether it's Europe, whether it's where, everybody who arrives in this country is requested to produce those tests. That is a mechanism to provide for us to protect us. We as South Africa, we were the first to complain and raise concerns when everybody started calling Beta a South African variant. We felt that we are being isolated. We felt that we are being ostracized in the midst of a pandemic. So you can't suffer twice, suffer from a pandemic and suffer from discrimination. And we can't be the ones who also go and say we must actually make other nations to suffer twice. But we are not saying we should not protect our country. So there is that clear indication of protocols and mechanisms that have been put in place, including within the community in terms of what we are doing. So I wanted to clear that. I think there's a misunderstanding of what the DM has said, and I think there's misunderstanding of what government has done in terms of protecting South Africans, and will continue to do that. So the other issue
Chairperson, the acting minister is misleading us here, Chairperson.
Agreed,
The minister is misleading us here. Many countries has put in restrictions. So don't say nobody has put in restrictions.
Honorable Imam Sheikh, you will not do that.
Order, Honorable Chair.
You will not do that when the minister is on the platform. If you are not happy with the question, if you are not happy with the answer, you know how to do it. You know how.
He's messing up a good meeting. He's messing up a good meeting.
Continue, Minister.
Honorable Imam Sheikh, we can have the discussion. Fortunately, one participates in global platforms that deals with these matters. so we can have a conversation and we can take you through how the decisions in countries are taken and what is being done so that we can be informed, all of us. So it's not out of a point of being informed. I'm speaking quite from an experience. I sit on the Sustainable Tourism on World Economic Forum. We deal with these matters quite regularly. And we are able to evaluate in terms of countries, what they are doing in terms of travel, and we can give you clear indication of why certain countries will have taken a particular decision and all that, so that you can understand why South Africa will take a particular stance in not taking that what you are saying we should have done. Just to indicate in terms of fast tracking of the vaccine rollout. Honorable members, one is not going to be here and say we are not concerned about how we've fared with the 60+ population. I think we've been open about it to say we would have loved to have finished the population by today, which is 60+. And out of that, now we had to go back and look at what has cost us not to reach this target. So part of what we are doing, hence we are looking at multiple approaches in terms of implementation of our vaccine program. Not only opening for the age groups, but also dealing with other sectors to be able to say, while you are dealing with the population, for example, when you look at the 50+, you are going to see it's almost 4 million population. But again, you are going to see that we are opening for the security cluster because these are the people that must help us in doing the work and managing the pandemic. So that work is done. You want to also keep the economy going. That's why you must vaccinate within the active economy so that when people move to their houses, go to the retail, we are not exposing itself, or either in terms of the taxes, in terms of the economy, what we call productive sectors of the economy. So that's what we are doing as well. So the multiple facet approach that we are taking is one of the things that we are ramping up and fast tracking the implementation of our vaccine rollout program. We'll continue to do that. We'll continue to evaluate. And I think that's what I said last time to say, when we look at our our vaccine program, there will continue to be improvements because we might have said, this is how we are going to. I think what is important for us is to be able to come back, check, where we have changed to say, honorable members, this is what we have initially planned to say, this is the rollout will go. We have changed on the following decision, and these are the reasons why it has been changed. One of the issues that keeps on coming up was the issue around that initially we said comorbidity. So the understanding of the population was that anyone, whatever age, who has a comorbidity will be vaccinated quickly with the 60+. But later, we only opened for 60+. Now, in clarifying this, when the matter was looked in terms of practical implementation, it was found that how do you prove that all of us have comorbidities? So the difficulty and then the category of 60+ was seen as a category that is more of population that have comorbidities and the vulnerable, as Dr. Pillay has presented. So that's how the decision was taken. So we'll go back as well, Honorable Van Staden, to really look in the issues around disability. Because part of what we must do is that when we take a decision to say this is how we are rolling out, let's look at the practical implementation of the process. I know with many disabilities, you have a certificate or a medical report, but there are certain disabilities that will not. So we'll have to look into that. How do we balance that? And maybe perhaps respond when we come in the next 2 weeks to say, we've looked at this. This is what we think is practical about implementation. So it's very important for us to be able to be transparent in how we do. And that's why I'm saying, perhaps maybe the weakness might be, as we come, would not say, this is what last time we said, and this is what we have reviewed. Because every week we review, we go to the IMC, and then the IMC looks at what we have been able to achieve, where there are bottlenecks, then also recommends. And the technical teams as well looks at how we are rolling out, how do we do in terms of implementation. So we're looking at ramping up as well the sites to be able to have more sites in terms of vaccine rollout. And that's why we can talk about success stories and learning out of success stories. So when tomorrow we come back and say, this is how we have changed it, we'll be able to account to say, this is what we have done. So that's the issue. Now, practical steps on non-pharmaceutical, the issue of field hospitals, honorable members. What we look at, obviously, one had to look in terms of where the field hospitals, and you would understand. Part of the issue was that many, for example, let's take Gauteng. Gauteng, when we engaged, we asked about Nasrec, and they say, no, look, When we had NASREC, we never even had full capacity in terms of NASREC. So when you looked versus the cost and the occupancy, it didn't make sense. But what Gauteng had done over time during first wave and second wave was to add capacity in terms of beds in the hospitals. So many of the provinces would have done that. As they disseminate or as they do away with the field hospitals, you'd find within the hospitals themselves, there's additional capacity that has been brought. For example, in Gauteng, we have about 1,400 additional beds. What would have affected Gauteng more is because of the absence of Charlotte Maxeke with the fire that no one could have anticipated. But when you look at the alternative technology buildings that have been brought, one in Jubilee, the second one in that we call Anglo Shanti, the third one in terms of Bronkhorstspruit, and the other one in Bar. Those, when you check in terms of capacity, then you see that the beds add in terms of what we need. Currently, when we evaluate, for example, in Gauteng, we do not have those beds fully 100% capacity. But another thing that we had to do in intervention is we look at what is happening and managing the pandemic, because sometimes it looks like we do not. There's a team that consistently look at what is happening based on the numbers and do interventions per province. Now, when you look at Gauteng, where there's pressure, it's the private sector. Now, I'm in contact with the Department of Health in Gauteng. We held a meeting between the Ministerial Advisory Committee together with the Advisory Committee of the Premier to look at whether we are missing each other in interventions, to close the gap so that we can make sure that we are on the same page, because some of the people who sit in the NEC are clinicians who have practical experience and what they're literally on the ground. And part of what we found is that the bed capacity is there. There are two areas where there's strain, which is the ICU and also in terms of the emergency area. Now, we do not have shortages of oxygen. That capacity is there. In terms of the ICU as well, it's around the turnaround time. And we looked at interventions to say, how do we respond to it? The other issue that we had picked up was around the turnaround time of sourcing of human capital, because to activate some of the existing beds, you need to have the human capital to be able to activate them. And that work, that's why the president, when he announced, he was able to say to us, Solidarity has brought in money to be able to recruit the nurses to be able to assist us within Gauteng. We are monitoring other provinces. We don't think where we are in trouble. Remember as well, the department has been in this committee to come and say, we have developed an action plan in response to a search together with WHO. And once we have a search, that's what gets activated. So all the provinces were given an indication to activate and get everything ready. And there is a reporting mechanism that continuously monitor what is happening in terms of beds across the country, in terms of oxygen across the country supply, in terms of ICU and all that. In Gauteng, for example, again, there's been a team that has been established jointly to look at sourcing when a patient goes to private sector, how do we transfer that patient into public sector? So that where there is gaps in terms of non-availability of a bed and the other side has an availability bed, there is smooth transition. The ambulance can know where to take the patient, not to go to a hospital that is full. So work is being done, honorable members, not that we are not listening, not that nothing is being done. Consistently every day, work is being done to ensure that we respond to the pandemic. And we do believe that as we emphasize what needs to be done by the department, we need to emphasize again the responsibility of citizens to be able to assist us to manage the pandemic. Again, all the gatherings have been stopped. No one should be encouraging gatherings, especially political parties, including all where we all belong, to not encourage gatherings. You must see leaders speaking out, because it's not only the responsibility of the department and the responsibility of healthcare workers to save lives, it's responsibility of all of us. Thank you very much, Chair.
Honorable members, we would like to put this to a close after the minister's address. Honorable members, if there are questions that you have not been satisfied in getting responses, you follow the same process that we do in Parliament, so it's not different here too. We would probably meet the minister in the next fortnight with an update. But Honorable Minister, we want to appreciate the the continued invitations that the parliamentary liaison officer, Mr. Khatla, sends to us. Just want to remind him to send it on time in case you are going to be appearing in other platforms addressing the nation or wherever you are meeting, maybe the scientists. We appreciate that because it is the information that we also appreciate to get to us. Honorable members, I wish we could have extended this. I know you are still wanting to ask, but we have to be fair to some of our staff members also have been here since this morning, and to some of us who started the meeting at 9 o'clock. Thank you very much. We would like to bring this meeting to a close. Thanks.
Thank you very much, Chair.